Hello, everyone. Welcome to this talk about diabetic retinopathy, which is aimed for my patients at the diabetic clinic at Sia County Referral. My name is Dr. James Wagude, and I'm the physician in charge of the clinic. Welcome to the talk. We are going to go through the introduction and the risk factors for diabetic retinopathy, how to classify it, what are involved in preventing and delaying the progression of diabetic retinopathy, screening and the management of diabetic retinopathy, and how to address visual loss once it has occurred. So in introduction, diabetic retinopathy is a common abnormality of the small blood vessels in the eyes, which is referred to as a microvascular complication of either type 1 or type 2 diabetes. About 1/3 of people living with diabetes have signs of diabetic retinopathy, while 10% could progress to such disease like proliferative retinopathy, according to data we have from the International Diabetes Federation Diabetic Atlas of 2025. Diabetic retinopathy is closely associated with diabetic control and duration of disease, and typically it's the reason for a majority of new cases of blindness in adults in many countries. Eye disease such as cataracts and glaucoma also develop much earlier and more commonly in people living with diabetes. The available risk factors that we know of that contribute to diabetic retinopathy from the IDF Diabetic Atlas include hypertension, lack of glycemic control, renal disease, high lipid levels, and duration and type of diabetes. So, a systemic review of several scientific studies to identify risk factors for progression of retinopathy in diabetes showed that an elevated glycosylated hemoglobin or HbA1c, presence of renal disease in either type 1 or type 2 diabetes, raised triglyceride levels, and progression of younger age of diabetes diagnosis are all associated with progression to proliferative retinopathy in diabetes. Another study done showed that significant risk factors for diabetic retinopathy included a long duration of diabetes, presence of elevated blood pressure, and cigarette smoking in such patients. In terms of classification for diabetic retinopathy, the most used system is the International Clinical Diabetic Retinopathy Severity Scale that was developed by Cleveland et al. In 2023. So this scale includes number 1, no diabetic retinopathy; 2, mild non-proliferative diabetic retinopathy, where only small bills in the retina are present, called microaneurysms; 3 is moderate non-proliferative diabetic retinopathy, which typically has various abnormalities such as retinal blots, microaneurysms, blood hemorrhages, hardware exudates, and cotton wool spots. The 4th is severe non-proliferative diabetic retinopathy with appearance of more than 20 interretinal bleeds or hemorrhages in all 4 quadrants, venous looping or beading in more than 2 eye quadrants, interretinal microvascular abnormalities in more than 1 quadrant, and a lack of proliferative retinopathy. The last and the most severe stage is proliferative diabetic retinopathy, where there is a presence of either neovascularization with new blood vessels created, or vitreous bleeding, and that is usually the most poor prognostic stage in retinopathy. In terms of prevention or delaying diabetic retinopathy, we know from large-scale randomized studies that intensive diabetic treatment targeting control of blood sugar has not been found to prevent and delay progression of retinopathy. Additional benefits from this intensive diabetic treatment include decreasing future surgeries in the eye and improving self-reported visual function, according to the ADA and UKPDS 33 study that was published in 1998. The Diabetes Control and Complications Trial, which was published also in 1993, had categorized patients with type 1 diabetes at random into conventional insulin treatment versus intensive insulin treatment for about 6 years. The results did show that intensive treatment, in comparison to conventional treatment, decreased the risk of diabetic retinopathy by 76% in type 1 diabetes, while delaying progression of diabetic retinopathy by about 54%. So this was a really landmark trial that showed control of your blood sugar can be a major attainment towards the goal of preventing diabetic retinopathy. In terms of screening, The ADA guidelines in America recommend that based on the type of diabetes, type 1 diabetic patients get initial dilated fundoscopy by an eye specialist right within about 5 years of onset of diabetes, while those with type 2 diabetes should get such dilated fundoscopy by a specialist at the very time of diagnosis. If no anomalies are found in either type of patients, then screening can be repeated every 1 to 2 years as long as diabetic control is good, while those with retinopathy should have more frequent examinations and progress to management. In terms of management, treatment options exist with those with severe non-proliferative retinopathy or proliferative retinopathy referred early to experienced surgeons or ophthalmologists, with the three main options for treatment according to the National Institute for Health and Care Excellence guidelines in the UK, including the three that I'll mention. One, laser panretinal photocoagulation. Two, intravitreal therapy with drugs called anti-VEGFs. And third is surgery, including vitrectomy. To elaborate more, laser panretinal photocoagulation, which is the first-line treatment for proliferative retinopathy in diabetes, has been shown by several studies to have a severe reduction in severe visual loss by more than 50%, and a lessened risk of severe blindness from proliferative diabetic retinopathy from about 15.9% before surgery to about 6.4% after therapy. Injections of antivascular endothelial growth factors, or the VEGF that I mentioned, or vitrectomy can be useful in patients who don't respond to the first-line therapy of photocoagulation or have much severe diabetic retinopathy. Other effective forms of treatment include controlling of your blood glucose, and as well as those patients with hypertension having a better control of their blood pressure. In terms of visual rehabilitation, patients living with diabetes who have undergone loss of vision need to be counseled on available options for regaining their eyesight by linking them to an experienced eye specialist, as well as educating them in self-care involving glycemic control and recognition of hypoglycemia according to the ADA guidelines. These same guidelines show that if you rehabilitate the vision of such patients, this improves self-management, increases their function and quality of life by preventing depression and self-isolation that is seen with blindness or vision loss. So this is a really important step in giving independence to such patients and retaining their self-care. With those few remarks, I hope you'll take the issue of screening for diabetic retinopathy seriously, and you will engage your doctor on your next visit on whether it's possible to have a screening done, and this should be maintained every 1 or 2 years if there's no abnormality found on such screening by fundoscopy. Thank you for listening to me, and have a good day. Thank you.